It's now question time, and we've got some online here. With some real crackers, actually. We are the people in this room, but just to let you know, there are over 300 people online streaming into this. So, and I think some of these, I know some of these questions do come from those people. So, so pucker up, guys and ladies. The first question goes to Rob. Rob, are you there?
I'm here.
Very good. So the first question is with profiling, with the molecular testing being done, what is the role of the pathologist?
I think, really sort of two parts of the roles. I mean, this is the question is asked for by people, by the oncologists to direct treatment. So some of the tests are done reflexly. We do them on every specimen. Some we require the oncologist say in this particular patient something is needed. So that's in terms of the actual requesting. In terms of the tissue, then we have to assess the quality of the tissue. Is it good enough? Is there enough of it to make it suitable for testing? And certainly when we have a resection specimen, really important to try and select the best block possible, so that in future, and it can be some time down the line, of course, as new techniques become available, there's something appropriate to be tested.
Okay, so the curator of the tissue.
We are the curators. That's a very good saying.
Thanks very much.
Okay, there is another question for Hassan, surgical question. If a patient has been advised that the cholangiocarcinoma is not operable due to the proximity to a main artery, is it important to ask for a second opinion?
So legally, you can have a second opinion, and even for us, we would encourage patients, if they felt that the decision that was provided by the tumour board, that we have the option of that. So that's absolutely fine, and it's your right. And it may be the second opinion agrees with the first opinion. I think where the difficulty, I guess, arises is do people go round and round until they get the opinion they want? And that opinion may not be reasonable, or it may be an opinion that puts the patient at risk and harm. So it's about balancing the opinion with the fact that the opinion is from a respected source or whatever it may be. And I agree. I mean, involvement of the future remnant liver hepatic arteries is a relative contraindication to surgery. And yes, you could go in and operate and hope for the best, but actually nowadays you'd probably go down the route of systemic treatment, and if you have a good response, then you may do a trial dissection. But also, if it's an appropriate case, then transplantation is an option. So these are all the things that we do discuss and have to balance. So yes, everyone's got the right to the second opinion, but it may still be the same as the first opinion. So and if that gives you the peace of mind to say, well, look, I've tried all the options, I think that's appropriate.
So the answer is yes.
Yeah, in short, yeah.
The answer is yes. Okay, great. So the next question, I think, goes to the CNS team. Please, what happens, and the question goes, what happens if you're at a hospital where the MDT doesn't have experience with cholangiocarcinoma?
So I suppose this goes to the second opinion, like what Mr. Malik's just said. So yeah, I would say that if your hospital doesn't, then it's important to find out where there is a hospital that does have expertise and ask for a referral, and that can be done by your GP. It doesn't have to be by your hospital team.
Okay. Anybody else like to chip in about that? Juan, Hassan.
So the reality is that when Helen and the team looked at the data in cholangiocarcinoma management in the UK, half the patients got no treatment whatsoever, as far as we can see. You'd hope that people are given a chance of an opinion from a specialist, and as well we know different MDTs are different, and the local district general hospital MDT may not have a liver surgeon, they may not have a oncologist who specialises in biliary tract cancer, etc. So in the past, that was an issue, but I know Shahid's led on the new cholangiocarcinoma British guidelines, and one of the specific recommendations will be, assuming it should get published, is that these patients should be discussed in the regional hepatobiliary MDT. So you'd hope that they'd get that expert opinion. So hopefully in the future this would be less of an issue, in the UK anyway.
I'd say, you know, if you're diagnosed with cholangiocarcinoma, you've got a lot going on, right? And it shouldn't have to be a battle. Sometimes it is. It shouldn't have to be that way. I think there are systemic issues outside our specialty. Many people don't know their GP. GPs don't know their patients because you don't have that same relationship that we had with GPs years ago. So every time you go to the GP, you see someone new. But at the end of the day, if you're a patient, you absolutely have the right to ask for a second opinion, and that has to be honoured. And you know, you might have to fight for it. You shouldn't have to, but I think the reality is that sometimes you do. So it's important to get your GP on your side, but you absolutely have that right, and to make sure that your case is discussed at an appropriate centre.
Yeah.
Thank you.
Thank you. There are several questions about radiotherapy, and two main points. One is if radiotherapy can be used if cancer has spread, and the other point is if the cancer has not spread, can we use radiotherapy together with chemotherapy or to relieve obstruction either of bile duct or main arteries?
Thank you. So in the first question, if the disease has spread, can we use radiotherapy? We can, but it will be with palliative intent. So that will be to try and manage symptoms. So the example I used earlier was if the disease had spread potentially to maybe the bone and cause a lot of pain, radiotherapy can be effective there. We wouldn't recommend, generally we wouldn't recommend using it for the primary cancer or using a protracted course of treatment, because once the disease has spread, if there is the option of systemic therapy, because it's already in the bloodstream, then systemic therapy would definitely be preferable. In the second part where you asked about local disease, so in this setting, we're waiting the results of the ABC07 trial, which looked at chemotherapy versus chemotherapy and SABR. And in this situation, what we're trying to do is twofold. We're trying to deal with the cancer that we can see, but also the cancer we can't see, so the microscopic disease, and that's what the chemotherapy is there for. And then we use something called consolidation. So you use the chemotherapy to try and control the cancer wherever it is, shrink it down, and then we're using the radiotherapy as almost like a sniper treatment to try and take out as much of it as possible. And in the final question about obstruction, I generally wouldn't recommend radiotherapy for patients who have obstruction, and the reason for that is one of the critical things that happens with radiotherapy is it causes a lot of inflammation, so it can actually make those areas which are causing the obstruction much more swollen, and therefore actually worsen things. So in the main, we don't recommend it for obstruction.
Okay, thank you.
Thanks very much. We've still got a load of questions. I don't know how much time we have. Maybe Gary can give us a warning shot. First of all, a comment. There isn't such a thing as a clinical nurse specialist in Germany, and we wish we had orchestra conductors like that. The question comes, and I think, Hassan, you're probably best. There appears to be a sharp contrast between the USA and other countries in terms of treatment. For example, stage 4 takes a number of options off the table, for instance, surgery, but not in the US. Is this a difference of philosophy, or is it a funding thing?
So It's difficult, isn't it? So ultimately, I show you that thing about the data for perihilar cholangiocarcinoma. I mean, this is an operation which, in that registry, which US centres have also put data into, the mortality, the 90-day mortality is about 14%. And then you add, the futile aspect. So I think you'd be, you'd have to, if you're going to take someone with a perihilar cholangiocarcinoma who's clearly got metastatic disease. Now, the question is, how do you define that? Well, you can have metastatic disease into the regional lymph nodes. Well, that isn't in our book stage 4. We would still resect those. But if you've got lung mets, you've got bone mets, you've got intrahepatic metastases, then that is something that is completely different. In the past, the Japanese would recommend resecting patients who've got intrahepatic cholangiocarcinoma, perhaps with satellite nodules and things. But again, the prognosis in these patients is far worse. And doing this type of surgery without challenging the patient with chemotherapy and demonstrating the biology, I think, is probably quite foolish. So it is a challenge, because ultimately, what we are guided by is, I hope, evidence, and sometimes the answer may be no, in terms of an operation, and it's really that decision's made on what's in a weird way, without sounding condescending, is the weird way is the best evidence we have for this clinical situation. But you'll always find someone who'll say, okay, well, we'll just do it, but then you have to look at the longer term outcomes. Just because someone's gone through an operation for stage 4 metastatic cancer of whatever description, do we actually have data to say that that's been beneficial in terms of long-term survival? That's the challenge. And if it has, then please present the data.
Juan is going to...
Yeah, just to add a comment. I mean, the one word I'd pick up on there, Hassan, is evidence. I think for many years we've told ourselves that these are rare cancers and we can't develop levels of evidence. The reality is, with enough collaboration, we can get now the evidence that we need, even in rare subgroups of a rare cancer. We're now changing the paradigm. So I think I would certainly encourage clinicians and investigators to design the clinical trials and patients to participate in those trials, so that we can really get a firm foundation on which to keep on building, rather than doing occasional heroic surgery or other interventions. And we know sometimes we got it wrong. So we all assumed that more chemotherapy was better, and now 2 triple chemotherapy combinations have failed compared to doublet chemotherapy, because once you do the actual trial to demonstrate the evidence, you actually find that your premise wasn't actually correct.
Can I just add one caveat to the stage 4 thing? There is this concept of oligometastatic disease, which I know we've discussed endlessly outside this meeting. So this is the idea that you can have metastatic disease that occurs in a limited number of sites and a limited number of lesions. And it's a very specific definition. And the hypothesis is that if you treat that radically, and that might be with an operation, a more likely ablative radiotherapy, then the intention of that treatment is cure. And so for a number of different tumour types, there have been clinical trials looking at ablative radiotherapy in oligometastatic disease. So certainly in the UK, currently, that radiotherapy is indicated for oligometastatic cancer. And that could be breast cancer, it could be cholangiocarcinoma, it could be a number of different things. And that's why it's important after the surgery that we follow our patients up with imaging and other modalities, so that if that limited metastatic disease is identified, there is another chance of treatment beyond systemic chemotherapy. So that is a very small caveat, and it only applies to a very small number of patients who relapse. But at the moment, it's not funded for patients who present with oligometastatic disease, even though it may be potentially ablatable or whatever.
Can I just add something to something that Professor Vallée was saying, that with improvements in systemic treatment, immunotherapy, targeted therapy, there may come a time when more advanced patients with neoadjuvant therapy may be more amenable to surgery. Cases that today we say is too advanced may not be in the future.
Thank you so much. We have to close this session. I think it was great. And thank you all for the discussion. There are several further questions here coming from the app, but unfortunately we have to close now, but we have time to networking here, at least for who are here in person. And so thank you all again. It was a great multidisciplinary team discussion, and we'll move on to the second session.